Can you see this screen okay? Hi everyone. So as Marie suggested, I'm going to talk about multimorbidity today. I'm Bhautesh Jani. I'm a GP and a clinical senior lecturer in the general practice research group within the institute. And I've been involved with multimorbidity research for some time now, along with my colleagues across the institute. So what I want to talk about is describe the scope of the problem of multimorbidity and some of the research which has gone on about measuring multimorbidity, various options which have been evaluated in managing multimorbidity and the direction of future travel. What I'd like to mention here is multiple research conditions is the preferred term by patients and not multimorbidity. While in the context of research and clinical practice, multimorbidity is often used. But if we are thinking from patients' perspective, we should be talking about multiple long-term conditions. But for brevity, I'm going to, from now on, I'm going to describe it as multimorbidity. So this kind of term started around late 90s by a group of GPs who noticed that comorbidity, which is defined as having one other condition in addition to your index condition, was very common. But not only that, people were found to have more than one comorbid condition. And so they came up with this term called multimorbidity, where by definition you have two or more long-term conditions. And since then, there has been this debate about whether it should be called comorbidity or multimorbidity, where comorbidity is the argument against calling. A lot of multimorbidity researchers argue that when we use the term comorbidity, you give undue importance to your index condition as opposed to the other condition which exists with that. Whereas multimorbidity is kind of taking a more holistic approach, and it's a study of two or more long-term conditions. Often these terms are used interchangeably in clinical practice, but in research field there is a clear distinction. So how common is multimorbidity? There is a systematic review or meta-analysis published in Journal of Comorbidity last year. They looked at 68 studies across high and low income countries, and they found a pooled prevalence of 33% in community population. The prevalence was higher in high income countries, which was 37.9%, as compared to low income countries, which was 29.7%. And the authors noted that this could be due to underreporting or other kinds of biases, and the difference may not be true. Also, they noted a lot of heterogeneity in the population which they studied. More closer to home, this was a study of 1.7 million general practice patients in Scotland, involving Stuart Mercer and Graham Watt from General Practice Research Group. And they found that overall prevalence of multimorbidity was 23%. But not only that, the prevalence was much higher in socioeconomically deprived group, which is represented by this red line, as compared to, and these are the different lines of the socioeconomic quintiles. The black line is the more affluent group, and as you can see, as the age increases, the rise in multimorbidity is much faster in socioeconomically deprived group as compared to the affluent group. Another study, more recent, using CPRD, about 500,000 people from CPRD, and they found an overall prevalence rate about 27.2%. This is the kind of five groups, five categories of socioeconomic deprivation, and green bars representing the most deprived group. And as you can see, in the younger and the middle age group, the prevalence is much higher. It stays high for a while, but in the elderly group, the prevalence kind of tapers off. So overall, you could say multimorbidity is common, and it's socially patterned, where the kind of onset is much earlier in socioeconomically deprived population. But so why is that a problem? So this is a study which I was involved with, looking at about 500,000 participants from UK Biobank, and what we found is that the risk of cancer mortality and cardiovascular mortality was far higher in people with multimorbidity. So people with 4 or more long-term conditions had 3 times more likely to have a cardiovascular related mortality, and twice more likely to have a cancer related mortality. This is a study from general practice population in the Catalan region in Spain, and they found that multimorbidity was associated with frequent primary care attendance, higher home care use, social needing more requirement from social care, and higher polypharmacy. This is a meta-analysis involving about 38 studies, mainly from Europe and America. And they looked at multimorbidity and quality of life. And they found that multimorbidity was strongly associated with poor quality of life. Finally, this is a recent survey involving more than 1,500 GPs from Denmark, and they studied that what was the relationship between having a lot more multimorbid patients and the possibility of having burnout among GPs. And no surprise there, they found that presence of having more multimorbid patients make you vulnerable to have burnout among GPs in Denmark. So multimorbidity is associated with mortality, increased healthcare use, poor quality of life, and more physician burnout. So we've got a problem. So we need to do something about it. And the question is, how do we? The first thing in dealing with the problem is to measure the problem. So that's the area I'm going to talk about next, about how do we measure multimorbidity. And the answer is not that simple. Lucy Sterling and her colleagues did a systematic review on how multimorbidity is measured, and they found 25 different measures which are demonstrated in this this spider diagram. I don't expect you to read all the small print, but it is this diagram just shows the complexity in measuring multimorbidity. So they've got different measures based on either just counting the number of conditions, and then you got some measures which would weigh the severity of the condition. So for example, something like having a coronary heart disease will give you a higher score than something like eczema, for instance. Then there are some counts which would be based on your risk of having poor outcomes. And then finally, there are some counts which are purely based on the number of medications which are prescribed to you. So what they recommended is how do you measure multimorbidity is depends on what you want to do, whether you have data with diagnostic codes or you've got data with just drugs, information on medications, and what kind of outcome you want to measure. And they recommended different measures. And as you can see, there's a lot of and there's no clear consensus on what's the best way to measure multimorbidity. But it gets even more complicated. So it's not just a score or index which you can use to describe multimorbidity. You can describe multimorbidity in terms of profiles or clusters of different diseases. And again, there has been a systematic review done on that for more than 50 studies. And they found that a lot of different types of statistical techniques were used to describe the profiles of multimorbidity, such as exploratory factor analysis, or cluster analysis involving diseases, or cluster analysis involving people or patients, and latent class analysis. So next, I would like to summarize by saying that it can be measured either by multimorbidity can be either measured by count or index, or you can describe the cluster of conditions, whichever way you approach it. And there's no consensus on best way of doing it, and heterogeneity is very common. So next I want to talk about what can we do to manage multimorbidity. So the first ever guidelines published in this field was in 2016 by NICE, or the National Institute of Clinical Excellence. And what this guideline described was the risk of multimorbidity with in terms of higher polypharmacy and high risk of hospitalization and mortality. And they suggested that the patients with multimorbidity would require a kind of a more holistic approach, and they may require more continuity of care. The guidelines didn't come up with kind of concrete flow charts or treatment charts of what should be done to manage this group of patients. And in 2016, there was a Cochrane review. They looked at 18 complex interventions in management of multimorbidity, and they did not find a single intervention which was effective. So it just shows the challenge in management of multimorbidity. Recently, there is a big randomized controlled trial in the UK, which involved patients from Scotland as well. It was called the 3D, or the three-dimensional approach trial, where the GPs gave more time, and they had a closer look at management of polypharmacy in multimorbid patients. And again, this trial failed to find a clear evidence of benefit by taking this kind of approach. So in spite of a huge amount of research done in this area, the clinical application of multimorbidity remains limited. And if I talk to my clinical colleagues, they are aware of the concept, but they hardly use that in kind of day-to-day clinical practice. There is a lot of heterogeneity in measurement. How do you capture this problem? And there is no evidence on effective management. So here lies the problem, in spite of vast amount of research in this field over the last 15-20 years. So where do we go from here? And this is kind of my 2 pence, or my suggestions on where multimorbidity research could benefit in future. So one is thinking about determinants of multimorbidity. So one of the papers coming out from my research group was the association between childhood maltreatment and the risk of not only multimorbidity but also complex multimorbidity. So adults who recalled having a difficult childhood had higher risk of having multimorbidity, and also complex multimorbidity, which is kind of defined as having 3 or more conditions from different medical systems. So this is an area where you could have a future a potential to reduce the development of multimorbidity. And then there is role of modifiable lifestyle factors, higher body mass index, unhealthy eating, and undiagnosed high blood pressure. To name a few are common modifiable risk factors, and these can be tackled to delay or prevent the onset of multimorbidity.
Just to let you know, Bhautesh, you've got 3 minutes.
Okay. Finally, there should be more kind of longitudinal cohort studies for studying the patterns of multimorbidity development. So majority of studies till date have kind of taken a cross section from a population and looked at multimorbidity patterns within that cross section. But what we need to know is what happens if to the young person with anxiety and depression in their 20s and 30s. What's the trajectory of development of multimorbidity, or somebody in their 40s who develop hypertension? So you need more studies in that area, which kind of aligns well with the data science theme and the determinants of health inequalities theme. And the second area of research is management of multimorbidity. And here I think the context is very important. So I was involved in a study comparing multimorbidity clusters in UK and China for people with diabetes. And what we found is that the multimorbidity clusters in China were completely different from those in UK. So the challenges are different. And that in that sense, we need to think about what context we are going to apply multimorbidity to find solutions for that. And secondly, there are successful treatment strategies from single diseases, which we need to now adopt and implement for. We don't know how these drugs or management strategies would behave if we apply them to multimorbid population. Just for example, if we give metformin, we know it works for patients with diabetes, but how well does it work for patients with diabetes with multimorbidity? Or for instance, the cardiac rehabilitation program, which works very well for patients after a myocardial infarction. What about patients with multimorbidity and myocardial infarction? So that brings me to the end of my talk. Thank you for listening, and thank you for inviting me to the Cross Team Seminar Series.
Thank you, Bhautesh. I'll do the clap in lieu of an in-person audience. If anyone has, or any questions that anyone has, can you please post them in the chat to panelists and attendees so we can see them and ask Bhautesh about his presentation. Maybe I kick things off. When you were talking about management guidelines, Bhautesh, they seem to be difficult to develop, was what I got from the research you were presenting. And I was wondering, is that possibly because different patients present with different combinations of conditions? Has that anything to do with it?
So that I think yes. So I think multimorbidity. What I was trying to say is that most of the guidelines, the way clinicians or the way GPs work is they rely on guidelines for when deciding what treatment to prescribe or how to manage a particular condition, and most of the guidelines you would see would only focus on single diseases, so they would not necessarily have you would have a nice flow chart saying this is what you do when you're managing blood pressure, for instance, and high blood pressure, and what medications to take, but there is nothing available to say what if they have multimorbidity and other health problems which would potentially make them more vulnerable to side effects to some of these medications, and so that there lies the clinical problem or the challenge.
Okay. And we have a question from Kate O'Donnell. What do you think are the most important priorities in multimorbidity research?
So, like I said, I think we need to study the context in which multimorbidity is experienced and managed, whether it is in context of certain diseases where we have clear guidelines. So I gave an example for high blood pressure, and how does multimorbidity make a difference with that? Or if it is in context of different kind of demographics, whether it is to do with different ethnic groups. So I was referring to a study where multimorbidity pattern was different in UK to that from China. So I think it is studying, rather than applying one system kind of fits all, one definition fits all approach, it's better to study it in the context of a specific group. And then we'll be able to find specific solutions to those problems.
Mm-hmm. I think we have time for one or two more questions. John Cleland is wondering what you think, whether AI would be able to help disentangle the problems with multimorbidity.
Yeah, I'm just reading the whole question from John. Yes and no. As I said, some of I think my understanding is that some of the problems which is facing multimorbidity is that it's not studied in the context of, going to John's example, in the context of heart failure, to the extent of studying different treatment strategies for that. So we've not tried different, talking about RCTs, we know that representation of multimorbidity in RCTs is not as representative as the general population. So whether artificial intelligence will make a difference, it possibly will. It depends on if it is studying the pattern of multimorbidity, and the question remains whether the traditional statistical approaches is AI any better than them? I've not seen any evidence that that's the case, and by defining more nuanced and complex patterns of multimorbidity, are we going to necessarily find the right solution? So I would say it's early days for that. I don't know the answer whether AI can offer solution.
Okay, and there's a question from Hamish Foster. Do you think we should measure multimorbidity in general practice, and if so, how?
Yeah, so do we measure multimorbidity in general practice? The answer is it depends on what we are going to do with it. If it's to take policy level decisions about how the resources have to be distributed, and at an area level or at a practice level, then multimorbidity can be useful. And there are different measures, and depending on the outcome you want to capture, whether you want to think about healthcare use, you want to think about quality of life, or hospitalization, you can use different measures to capture multimorbidity, and that can guide you in and kind of making policy level decisions at a higher level or at the practice level of where you should be focusing on what group of patients. But at an individual level, should we be measuring multimorbidity? Unless we've got solutions for them, unless we've got tangible solutions and interventions, I don't think there is any clinical benefit of measuring multimorbidity at an individual level.
Okay, and one last question from Vittal. What do you think are the policy priorities in terms of preventing multimorbidity?
I think we could approach this at a public health level and think about all the kind of modifiable lifestyle factors which we know about, which could make a difference. We don't know which factor contributes to what level in different types of multimorbidity, but we can think about kind of a policy macro level interventions for improvement in lifestyle factors such as smoking and healthy eating and obesity prevention. And then there is at an individual level about how can we identify the trajectory early for development of multimorbidity, and whether we can whether we can identify these individuals who are vulnerable and have an early intervention which can potentially stop that trajectory of developing multimorbidity, especially in a deprived population where we know the onset is in middle age and often 10 or 20 years earlier than affluent population.
Okay, thank you very much again, Bhautesh. I think it's now time to introduce our second speaker, which is Vittal Katikireddi, who will talk to us about premature mortality among second-generation migrants in Sweden, which is a multi-generational data linkage study. Great, and again, Vittal will talk to us for about 20 minutes, and then we should have roughly 10 minutes time to take some questions afterwards. Over to you, Vittal.
Excellent. Well, thanks everyone, and thanks very much for the invitation to speak today. I'm going to present an ongoing study and some interim findings rather than providing a broad overview of a topic. So a slightly different approach to things compared to Bhautesh's talk, but hopefully it'll be good to get some discussion with feedback about some of this ongoing work and what we might be able to do to take it forward. Okay, so as if you can take your mind back to around kind of January, February or so, when I was first asked to give a talk, and this is that rescheduled talk. At that point, the issue of migration was still very much in the news, and especially in Europe. So it had been quite a politically sensitive area across many European countries, with concerns over the last several years about both the volume of migration, but also particularly some of the health experiences of migrants. So actually, one of the things that surprised us to some extent was how poor the data often are. So it was in that background that we wanted to try and address some of the data gaps, and particularly in terms of the offspring of migrants. So I'll come on to that a bit more. Just to say, from a UK perspective, over the last kind of 10, 20 years or so, the focus has tended to be very much on ethnicity more than migration status. And in terms of understanding death, so obviously from a health point of view, we're very interested in trying to prevent death, or at least delay it. But actually, the amount of studies that report on mortality by ethnicity are very limited. So Scotland is one of the few countries which has looked at mortality risks by ethnicity, and perhaps slightly in contrast to what the public perception might be, for many minority ethnic groups in Scotland, mortality rates in normal times, so not during the COVID pandemic, but normally tend to be quite a bit lower than the white Scottish population in terms of all-cause mortality. However, as I've said, that's focusing very much on ethnicity, and we can think of ethnicity as including several different dimensions. So some of those dimensions might be based on what people look like in terms of their physical features that are traditionally associated with ideas of race. Generally, it's worth noting that actually there's very small differences in terms of genetics between races. So actually the health differences we observe between races tends to be more about how people are treated within a society rather than actually the effects of race itself. But there's other aspects of ethnicity as well. And we can think to some extent that someone's ancestry and where they were born often influences their perceived ethnicity. So that's, if you like, one aspect that we might be particularly interested in. So within the UK, and I've just given England and Wales as an example here, you can see that the percentage of people who were born abroad has increased substantially over time. And this is the same in many countries, not just high-income countries, but kind of throughout the world. And the migrants might experience specific health impacts as a consequence of being a migrant. And one way of thinking about the factors that might influence their health is thinking about the environment they grew up in, so their country of birth. They may have, for example, been exposed to specific diseases in childhood or things like that, or specific exposures. There might be risks associated with the actual transit process of moving to another country, especially for certain groups like, for example, asylum seekers, where they might have a more prolonged transit process, and actually once they get to a new country, the way that migrants are treated within a new country might influence their health as well. And it's worth noting that actually for many migrants will return back to their country of origin. So the kind of classic example of that would be students. So apologies for this crowded slide. The main thing that I'd like you to take away from it is that this is a systematic review of mortality amongst migrants compared to their destination country's population. And what you can see is every data point to the left of the vertical line suggests a lower mortality rate, and every data point to the right is a higher mortality rate. And as you can see, generally migrants tend to have lower mortality rates. And that's quite a well-observed kind of feature across the world. It's worth noting that this is specific to all-cause mortality. So there are certain health risks which are higher amongst migrants, but at least in terms of mortality, this tends to be the picture. So given that background of generally migrants tend to have lower mortality, we were interested in trying to look at the experiences of the offspring of migrants who've generally been less well studied. The studies that have been done have suggested that often the offspring still tend to have relative health advantages, but perhaps less so than their parents. So that's what we found within the UK, for example. However, that's not universally the case. So it does vary depending on the specific group you're studying. So for example, if there are offspring of migrants who are particularly experiencing socioeconomic disadvantage, then there do seem to be some cases of greater mortality. However, usually we've not really been able to find many studies that have looked at the mortality risk of second generation migrants, so the offspring of migrants. I appreciate that particular term isn't ideal, but in terms of the offspring of migrants who have one parent from the destination country and one migrant parent, there are reasons to believe that their health could potentially be better or it could potentially be worse. And there are kind of arguments in both directions. So in terms of potentially being better, it's possible that by having a parent from the destination country, they might be able to settle into that society more easily. In contrast, there's the suggestion that actually people might experience a sense of conflict with not necessarily feeling part of their country of their parents' country of origin, but also not necessarily feeling fully part of their current country as well. So that's the alternative kind of viewpoint of a potential cultural conflict. So we wanted to try and understand, well, what does the data suggest about mortality rates for the offspring of migrants? While I was in Sweden at some point last year, we realized that the Swedish register data would allow us to actually study this. And but because of the nature of Swedish migration, we were only really able to look at deaths before the age of 50, because actually the most migrants in Sweden tended to be fairly young, And if we're interested in the offspring of migrants, then we're talking about an even younger population. So what did we do? Well, so in Sweden, a bit like Scotland, they have a population register. So everyone who lives in Sweden has a unique personal identification number, and that information is included in all of their main data sets. So it's included in their mortality data, and also they have a migration register, which keeps a record of when people move in and out of the country. And there's also a register that records who the parents are of different offspring. So we were able to use deterministic linkage to bring together these data sets for the population of Sweden, and we focused on everyone who was born in Sweden after 1947. And because of the nature of the kind of death records we had available, we studied everyone who was resident at some time between 97 and 2016. So around 20 years of follow-up. And we excluded people with missing parental data. So as you could probably guess, in most cases that would tend to be missing information on the father, but it was actually a relatively small proportion of the sample. And we were studying, in addition to all-cause mortality, we studied 3 types of mortality that try to give you a sense of the kind of policy importance. So amenable mortality are deaths which, in theory, you should be able to avoid happening through healthcare. So things like, for example, appendicitis, you could would fall within amenable mortality. Preventable mortality are deaths which you would hopefully be able to avoid through effective public health interventions and policies. So deaths due to which could have potentially been prevented due to screening, but also things like smoking and alcohol as well. And avoidable mortality is a mixture of the two. So some deaths are potentially both amenable and preventable. So actually avoidable mortality is a bit less than the first 2 added up. So those were the things we were interested in looking at. In terms of how we classified our exposure groups, so we had 2 different ways of doing it, depending on parental origin. So we looked at whether people had Swedish parents, migrant parents, or whether there was 1 Swedish and 1 migrant parent. And then we used a slightly more refined approach, which I won't really get into in too much detail. Just to explain that due to potential issues about people maybe moving a bit more between the ages of birth and age 5, we actually started follow-up from age 5 and ended it at age 50 or death or moving out of the country. So with the study, we followed up 78 million person years of follow-up. During that, we observed 73,000 deaths, and you can see there a sense of how many people we were looking at. So out of the offspring, around 3/4 had 2 Swedish parents, and then slightly more had 2 migrant parents compared to mixed parents. So what did we see in terms of all-cause mortality? Well, these are really, I suppose, the kind of key results. And as you can see, compared to having 2 Swedish parents, people who had migrant parents and mixed parents had higher mortality risks, especially amongst men compared to women. But people who had two migrant parents had an even higher mortality risk compared to having one Swedish and one migrant parent. Just to say, we did look at whether it mattered if you had a Swedish mother or a Swedish father, but it didn't really seem to make a big difference.
Just to let you know, Vittal, this is, and you've got 5 minutes left.
Okay, great. So this is just to give you a sense of what the results looked like when we used that slightly more refined categorization. And you can see that actually some of the highest risk was in people who had two European parents. And some of that might be related to Finnish people in particular, but we can discuss that later. And when we looked at the type of death, you can see that actually a lot of the excess risk tended to be preventable mortality. So it suggests that actually public health measures might be particularly important, but also that some of the deaths were amenable, so that there is a potentially important role for the healthcare system to play as well. So just to summarize then, what we found was offspring of migrants tended to have higher premature mortality, with the offspring who had a mixed parental background having a moderately increased mortality. And just to say, to finish off in terms of think about some of the policy implications, in some of our previous work, we've found that actually the policies that a country has towards migrants can make quite a big difference to the health of migrants. But something that I think remains quite a big gap is understanding if any of those health impacts might then track to their offspring as well. So these are things like, for example, the hostile environment policy, for example. So just to finish off, in terms of thinking about where to go next, I think it'd be really interesting to try and understand a bit more about whether these patterns, whether similar patterns are seen in different countries, to be able to look at more detailed course-specific analyses, and also to look at what might be some of the mediators here. So, for example, are socioeconomic differences particularly important in explaining the patterns we're seeing? It's quite noticeable that actually there does seem to be this reversal of the migrant advantage within Sweden. And that's something which I think we need to investigate further, but also see, is that just Sweden or is that quite a common thing across countries? And hopefully, I think we do need to do some work to think about whether there needs to be a public health response to ensure that the offspring of migrants do not experience preventable deaths. So that's the end of my presentation. Just like to acknowledge the funders and yes, look forward to discussions.
Thank you, Vittal. Here's my clap on behalf of the audience. Have we got any questions for Vittal? Can you put them in the webinar chat, please? Just gonna give people a moment to type. We have a question from Hamish Foster. He would like to know what do you think explains the reversal of the migrant advantage, and why is there an advantage, and yeah, why does it reverse?
Okay, well, So I think this issue of why is there advantage has been kind of discussed hugely. I think generally most people would say that a lot of it is about, if you like, selection effects. So often people who choose to migrate tend to be the healthiest within their country of origin. So when people move, then that particular population tends to be very healthy. In terms of why it might reverse, so there is a chance that kind of broader issues of kind of structural discrimination and racism that are experienced in the destination country might come into play. But I think we need to investigate that. So, for example, I think looking at whether socioeconomic differences in between the offspring and others who are born within Sweden would be an important kind of next step to look at.
Okay, and Kate O'Donnell would like to know if there is a greater proportion of some types of migrants, for example, asylum seekers, and could disadvantage in early life due to parent status explain some of it?
Yeah, that's a really good question. So unfortunately, because we're looking at the offspring of migrants, we run into quite small numbers of people, and well, in particular, thankfully, small numbers of deaths, because it is quite a young population. So we've had to use quite broad groupings. One of the things that is quite noticeable, though, is actually some of the higher mortality is among groups who you wouldn't expect to be comprised of asylum seekers, for example. So even among some of the European migrants, there doesn't, some of them also seem to have a higher mortality risk among the offspring. So part of that might be kind of specific to the Finnish population, who kind of is well known to have a high levels of alcohol consumption, and that often drives their high mortality risk, especially at this age. But it doesn't seem to be only focused on the Finnish population. In terms of the non-European migrants and their children, that's a bit more difficult to look into just with the numbers of people we currently have. It's something we'd like to do, but we might need to look at kind of a broader range of outcomes rather than mortality.
Okay. There's also a question in the Q&A from David Blaine I just saw. He's wondering, how does the hostile environment for migrants in Sweden compare to that in the UK? That's a good question. So Sweden, I think historically, I think Sweden was perhaps a bit more welcoming. I wouldn't claim to be an expert on kind of Swedish public policy, to be honest, and kind of political views. My impression is there's been a move from a more kind of left-wing governments towards slightly, more of a right-wing focus and anti-immigration viewpoints over the last kind of decade or so. But I don't really have any particular statistics to back that up. I think that's more a kind of a general impression. So I apologize. I've realized that the sunshine started streaming through the window, so you can't see me anymore, but probably no bad thing. I think we have time for one last question from Bhautesh. He's wondering if mental health could have a big role to explain some of the findings. Has there been any studies suggesting second-generation migrants tend to experience more stress than first-generation migrants?
So there's some literature. So generally speaking, yes, in terms of second generation, so the offspring of migrants, often certain groups have higher risks of poor mental health. The evidence on people with kind of mixed parental background is much more limited. There is some evidence to suggest that. It's something which we have been thinking about doing a systematic review on, to actually try and more formally establish actually how much literature is there. Generally speaking, I think the looking at kind of mixed parental backgrounds has been much more limited.
Okay. Okay, I think it's time to close the seminar. Thank you again to both of our speakers, Bhautesh Jani and Vittal Katikireddi, and to everyone who was able to join the seminar as well. Thank you for taking part. And just to say again, if anyone has any feedback on the timing of the seminar or the format we've chosen, please feel free to email us. You can email me. It's marie.kotzer@glasgow.ac.uk. And also we're very happy for suggestions of any speakers to invite to our future meetings. Okay, so thank you again for joining, everyone.
Thank you.
And I hope to see you at another meeting sometime soon. Bye-bye.